Good afternoon. Today is Thursday, January 18th. You are in the Finance Committee. Thank you all for being here. If you have a cell phone, please turn your sound off, your ringer off. We will be bringing up the first thing we're going to have is two briefings. When we get to the bill hearings, we'll have a 2-minute timer on testimony for the bill hearing. So some people are already testifying in other committees. That has already started. And that's where this senator's going, and my vice chair is in a committee. So, but as long as we have 6, we can start. So we're going to start today. And the first briefing today is the overview of the commission to study the healthcare workforce crisis recommendations. And we have Kimberly Link from the health boards and Casey, and I'm going to say your name wrong, Casey, and I've been talking to you for 2 years, Tiefenworth from the Maryland Department of Labor.
Got it.
And so they've been chairing the committee, the work groups on the workforce, the healthcare workforce, and thank you both for being here.
Thank you. Good afternoon, Chair Beidel and members of the committee. My name's Kim Link. I'm the Senior Advisor for Boards and Commissions to the Secretary of Health, and I served as the chair of the commission to study the healthcare workforce crisis in Maryland. With me today is Casey Tiefenworth of the Maryland Department of Labor's Division of Workforce Development and Adult Learning. And Casey also served as the chair of the Workforce Data Advisory Group on the commission. It's been an honor to serve as the chair of the commission, and I'd like to express my gratitude to Senator Beidel and Senator Kelly for sponsoring the legislation establishing the commission and for their support and participation throughout the process. I'd also like to thank Senator Lamb for his active participation as a member of the commission. The commission was composed of 24 members from the legislature, state agencies, offices, and institutions, each of whom dedicated their time, knowledge, and expertise to this important work. The commission was fortunate to have over 70 stakeholders who actively participated in the advisory groups and made significant contributions by providing important feedback, data, and presentations. Oops. Stuck. There we go. Am I going the wrong way? One second. Nope. The next. Nope. Sorry, there we go. Different mouse. Over the 15 months, the legislative mandates to the commission were numerous and comprehensive. To address the mandates, 3 advisory groups were established: the Workforce Data Advisory Group, the Education and Pathways Advisory Group, and the State Efficiencies and Cooperation Advisory Group. Members of the commission from relevant state agencies and institutions were assigned to one or more advisory groups and were asked to provide workforce information. External stakeholders were also invited to participate in each of the advisory groups. Over the 15 months of the commission's work, the advisory group sought to gather and analyze as much data on the workforce as possible in order to provide this committee with information from which it can make sound policy decisions. The commission learned that many state agencies and stakeholder organizations have done a considerable amount of work to study and address the healthcare workforce shortages. Today, we'd like to highlight the commission's key findings and recommendations. More detailed information is available in the final report. You help me with the next one. Prior to the pandemic, many critical healthcare occupations were already experiencing or projected to experience a workforce shortage. For example, a 2017 report by the U.S. Department of Health and Human Services showed a gap existed between the supply of nurses and the projected need, citing Maryland among the top 6 states facing a deficit of licensed practical nurses by the year 2030. A nursing workforce study conducted by the Maryland Hospital Association found that registered nurses and licensed practical nurses will see up to 57% demand in growth in home health, nursing homes, and residential care by 2035. In addition, a 2019 survey conducted by the Maryland Department of Health's Behavioral Health Administration found that there are shortages and high turnover rates for professions such as social workers, case managers, and rehabilitation specialists. Maryland has experienced slower growth in healthcare employment compared to other states in the region, and nationally. Maryland is not restoring its pre-pandemic healthcare workforce at the same rate as other states. While most states in the Mid-Atlantic region have not fully returned to their 2019 level of employment in the healthcare sector, Maryland's post-pandemic recovery rate is lower than most other mid-Atlantic states. Next slide, please. Healthcare workforce shortages are most pronounced in rural areas of the state. According to the Health Resources and Services Administration, Maryland has 76 primary care health professional shortage areas covering 1.7 million residents. To eliminate the primary care HPSA designations, Maryland needs an additional 354 primary care practitioners. Similar shortages are present for dental health and behavioral health professionals. Next slide. Despite Maryland lagging behind other mid-Atlantic states and the nation in its ability to grow the healthcare workforce, there is some promising news. Maryland community colleges continue to produce graduates in healthcare-related majors at a significant rate. The commission worked with the Maryland Longitudinal Data System Center to gather data related to community college graduates. The Workforce Data Advisory Group focused on community college degree production because of the higher likelihood that those graduates would stay in Maryland upon entering the workforce. MLDS found that at community colleges in rural parts of the state, health-related degrees account for 30 to 50% of the degrees conferred. Some health-related majors include nursing, physical therapy assistants, dental hygiene, pharmacy technician, addiction counseling, EMT paramedics, respiratory therapy, and geriatric aides. MLDS also analyzed wage visibility for community college graduates in healthcare-related majors. This analysis revealed that Maryland is losing its most experienced healthcare professionals within a decade of their entrance into the workforce. Although there are multiple factors that can contribute to the loss of healthcare professionals, one reason may be stagnation of wages. MLDS, their analysis revealed that although wages double for these graduates over a 10-year period, the wages appear to stagnate between years 3 and 10. Slide. The commission was also tasked with examining the relationship between the Maryland Department of Health and the health occupation boards. The Education and Pathways Advisory Group surveyed the health occupation boards in a number of areas. There are 20 health occupation boards that are considered units of the Maryland Department of Health and are statutorily independent with regard to licensing, investigations, and disciplinary matters. At the request of the commission, the National Conference of State Legislatures researched the organizational and funding structure of health occupation boards in several states. The council determined that there was not one consistent model between states. Some health occupation boards are housed under umbrella state agencies and others operate independently. Most boards in the comparison states are funded by licensing fees that are set by the boards or the state agencies. The health occupation boards in Maryland issue approximately 115 different licenses, registrations, and certificates and regulate over 400,000 healthcare professionals. Over 1/2 of the licensed healthcare professionals in Maryland are regulated by the Board of Nursing. The commission found that 1/2 of the boards do not accept online applications for initial licensure and do not accept electronic payment for initial licensure applications. All of the boards do not share one common licensing platform. The survey responses varied by board. With regard to application backlogs, some boards reported that they were unable to provide that information. Others reported there was either no backlog or a backlog of very few to up to 240 applications at the time of the survey. Many boards reported having temporary licensure options, and all the boards report compliance with the federal law regarding expediting licensing for active duty service members and their spouses. So we'd like to give you a few updates since the formation of the commission. And last year, Senate Bill 283 was enacted, and that was the Behavioral Health Workforce Investment Fund. The purpose of the fund is to provide reimbursement for costs associated with training, recruiting, placing, and retaining behavioral health professionals and paraprofessionals. It also requires that the Maryland Healthcare Commission and others complete a comprehensive behavioral workforce needs assessment. In addition, SB 187 was enacted last year, which allows applicants to the health occupation boards to use a tax identification number instead of a social security number. This may remove a barrier to entry into the workforce for those applicants who do not have a Social Security number. In addition, the Health Occupation Board's report compliance with the Federal Veterans Auto and Education Improvement Act of 2021, which allows active service members and their spouses the ability to work in Maryland if they're licensed in another state. Most recently, the Moore-Miller administration announced $5.8 million in grants through the Maryland Higher Education Commission to help address the nursing shortage, and an additional $2.8 million in grants for the Nurse Support Program too. There are also several bills that have been introduced so far this session that could impact the healthcare workforce development. These include bills related to apprenticeships, interstate compacts for advanced practice registered nurses and social workers, and funding for wages and benefits for nursing home workers. As the commission began to receive and analyze data from member agencies and stakeholders, it became apparent that there is a need for a state healthcare workforce data center, a centralized repository of data from key agencies. Current data sources are often siloed and do not account for the interconnectedness of the allied healthcare system. There are gaps in the data from federal, state, and independent organizations, which make it difficult to determine the supply and demand for any given healthcare occupation. For example, on the healthcare supply side, and I'll use nurses as this example since they make up a large part of the healthcare workforce. The data collected by the Health Occupation Boards does not consistently include demographic information, information about work settings, geographic locations, or specialties. We may be, for example, we may be able to tell how many registered nurses are licensed in Maryland currently, but we cannot determine if they work in Maryland or in a neighboring state. If they work in Maryland, we're unable to determine in what region of the state they work, what their specialty is, and what type of setting they may work in. Do they work in a hospital, doctor's office, academia, or they may not practice in the healthcare field at all. Consistent data points collected across health occupations could also inform about demographics, attrition, and retirement trends. On the demand side, Maryland relies largely on federally defined measures such as provider ratios or facility level vacancy rates to determine healthcare occupation shortages. These measures may not adequately reflect the needs specific to Maryland. A workforce data center would collect, analyze, and disseminate data regarding supply and demand trends, geographic distribution of healthcare occupations, and demographic information about healthcare professionals. Several states have some version of a data workforce center or clearinghouse with varying capabilities. Some states are able to survey their licensees at the time of renewal to inquire as to changes in work locations or settings or worker retirement trends. These states are able to monitor the trends for specific healthcare occupations and perform more detailed research, as well as develop solutions tailored to that particular issue. The Maryland Department of Health's State Office of Rural Health has worked with the Primary Care Coalition of Montgomery County to develop a landscape analysis to inform the creation of a statewide clearinghouse. The department will brief the committee later today on that effort. Next slide. Some other recommendations of the commission include relate to the retention of healthcare professionals. Retention of healthcare professionals is equally important to the recruitment in health occupations. The data provided by the MLDS shows that wage visibility decreases at 5 and 10 years post-graduation. Specific recommendations from stakeholder organizations can be found in the final report and largely address increasing funding and or the expansion of current programs, including the loan repayment programs, examining changes to licensing requirements and scope of practice, and examining current Medicaid reimbursement models, as well as expanding statewide capacity for the education of healthcare professionals. With respect to the Maryland Department of Health and the Health Occupation Boards, the commission recognizes the important role that health occupation boards as it relates to workforce issues. The timely issuance of licenses to qualified professionals directly impacts the number of providers in the workforce. The health occupation boards also have the potential to collect important workforce data information that could assist in addressing shortages. The commission recommends that the Maryland Department of Health and the boards continue to explore opportunities to work collaboratively to gather relevant workforce data, streamline administrative functions, and to reduce potential barriers to licensure and to provide exceptional service to the citizens of Maryland. With that, we'd be happy to take questions.
Senator Klausmeyer.
Yeah, just a quick question. Has the commission ever looked at going, you know, talked about going from the state to here, but going to other countries? Because I know there for a while we were getting Philippine doctors and nurses and all. Are we looking at other countries to just try to persuade people to come here?
Thank you for the question, Vice Chair. The commission did not specifically look at recruitment from other countries into the United States for these professions, but it did look into the challenges that face foreign trained professionals, and to examine how we could lessen or eliminate some barriers that they may have. And the Education and Pathways Advisory Committee looked into that. And one of the answers was to help those who may not have Social Security numbers by using their tax identification number and other efforts.
So, okay, thank you.
I'm not sure who was next, but Senator Lamb. Just go down there.
Sure. Thank you, Madam Chair. Really just to kind of answer the Vice Chair's question there, one of the challenges is that foreign trained healthcare professionals, particularly physicians coming here, would still, at least the way it's currently configured, still need to go through a residency training before they can actually get licensed as a physician. There have been bills that have come forward before this committee, for example, from Delegate Lewis that came over last year, that looks at different ways that we could streamline that process to allow some of these foreign trained physicians to still practice without having to go through all of that training again. I'm sure we'll be seeing that bill coming forward again, probably from the House.
Just think that if we are under the gun to say that, you know, we are so short on this, we need to get creative. And that's what made me think that go to another country. And then there's certainly places that people would say, yeah, we'll come over, just get a visa or whatever to help us at that point. So thank you.
Thank you, senators. And Senator Washington.
Thank you.
Thank you, Madam Chair. You mentioned earlier that we are still behind on, we have high shortages. We haven't reached pre-pandemic levels. But then you also mentioned, and in comparison to other states, what are other states doing that we're not doing outside of the recommendations that you made here? Or are these the recommendations are these the policies that they're implementing?
Sure.
So hopefully you can hear me. So I can't speak to what all of the other states are doing, but what I would like to talk about is Virginia specifically. So Virginia is the only state in the Mid-Atlantic that has reached and exceeded its 2019 level of employment at 14% growth. And so when we, as a commission, looked at specifically the healthcare workforce databases, Virginia also has what can be considered sort of the gold standard in healthcare workforce databases. And so that's not an exact, correlation between why they've experienced growth in the way that they have, but certainly they're taking some steps, to examine their supply and demand, I think, in ways that they can then use to address those shortages and get creative, as Senator Klausmeyer mentioned.
I understand that having a database is great. Sounds great, but are they paying more? Are they reimbursing these professionals at a higher level than we are? Is the cost of living less there than it is here? What is it, is what I would like to see. I mean, if they're the gold standard, there's got to be something they're doing that we should be doing to attract them. So if you can possibly find something that makes us a little different from them, that'll be really helpful.
Absolutely.
And I did see in here about the governor's proposal on new funding. Has that been implemented yet, about the 2.8 million or the 5.8 million grants through MHEC and 2.8 million grants through MHEC for nurse support program 2? Do we have any those? I mean, those were those this year or those from last year? This this current fiscal year we're in.
Thank you, Senator Washington. So I just got the announcement on that over my feed from the governor's office. So that's new,
Oh, so this is just happened.
just happened.
Well, all right. Thank you.
Thank you, Senator Washington. Senator Mount.
Thank you, Chairman. Thank you, Madam Chairman. I apologize. So in the commission, in the report and the information you put together, did it focus at all on training in high school?
So, did you want, okay. The Education and Pathways Advisory Group took a look at programs that are available in high school in order to help transition people into the professions sooner. I don't have the exact data in front of me, but be happy to provide that for you.
Yeah, because and I know Cambridge South Dorchester, that's a school that's got all kinds of things going on right now. They graduate nurses, 12th grade. They come out, they have they can go right into the healthcare field. And there are also efforts to build mini med schools in elementary and middle schools to try to expose, and this is a rural area, to expose these students to healthcare at a young age. And there are studies that show that with that exposure, that's a great way to grow your own. And this isn't an immediate fix. And I know that one school program is a progeny of one or two individuals' work. However, I think it's been very productive. Because those students can then go on there, they enter that workforce, and that workforce pays for their college, so they'll do both. But and that's in conjunction with Chesapeake College. And I with the blueprint and this concept of, you get to your senior year and you're supposed to be doing an apprenticeship. We're talking to high school kids that are employable at that point. And I didn't hear it mentioned. And I would just recommend you to consider that, because I think it's a very important part of whatever long-term plans coming along, because clearly that's in the future, for education. And I know it's worked on the shore.
Great, thank you.
If I can just add too, I continue to have meetings with some of our hospitals and healthcare professionals. And I think because this group's been brought together by this commission, we're seeing the hospitals are doing a lot more with training employees that are already there. For instance, you may be a transporter transporting patients to a room, but they're providing the opportunity for you now to study for your LPN. And they're providing the funding and even in some cases daycare for the parents that are in training. So I do think, this commission has brought to light how serious the issue is. And it was great working with both of you. And I think you're going to continue the work. Is that the plan?
It's my understanding that the commission is complete with the submission of its final report.
Well,
But
we may re-engage you, Kimberly. Thank you.
But I will say to add on to that, if I may, Senator Beidel, that the commission has been a wonderful opportunity to bring all of these people into one place, because there's a lot of work. We've known about workforce shortages for some time. And that awareness has really, there's been a lot of work done by professional associations and state agencies, and the commission allowed for all of us to be in the same room, so to speak, to find out what everyone else is doing. And I think before that, it was very separated and no one was really sure. And there may have been duplication of effort. And I think this has allowed both the private sector and the public sector to really come together to explore the issue. And you're correct. There are a lot of independent and private professional associations that are doing a lot of work on this in terms of recruitment and retention.
We talked about the data center, and I had the opportunity to meet with the senator from Virginia that had the bill 10 years ago to develop their data center. He and I spoke at a conference together. And I do think it's made a difference. I think having the data to know where the shortages are and where the workforce, like we said, we don't know if nurses are working in doctor's offices or insurance companies or in hospitals. So it seems like that has really helped Virginia figure out what they need to do to have their professionals in the right places. And I think we're, continue to do that. So thank you both again. Do I have any other questions from any senators? No? Thank you again.
Thank you.
So our next briefing is from Dr. Kalyana Raman. He is the Maryland Deputy Secretary for Public Health. He was my health officer in Anne Arundel. That's why I can pronounce his name. It took some practice, but we started calling you Dr. K. So Dr. K, welcome to the Senate. Thank you.
Thank you, Chairwoman Vital, and thank you to the committee for having us here. Let me advance these slides. There we go. So as Madam Chairwoman noted, I am Dr. Nilesh Kalyanaraman, the Deputy Secretary of Public Health at the Maryland Department of Health, and I wanted to focus today on our current efforts on bolstering the healthcare workforce. So when we look at our workforce shortages and particularly our health professional shortage area designations, we see that 23 out of the 24 jurisdictions in the state had some kind of shortage, with only Howard County not having any of the HPSA shortage areas. And of those 23, 22 of them have primary care and behavioral health care shortages. HRSA does provide funding to improve funding to states to improve access to healthcare through the management of data and federal criteria to determine eligible areas for the shortage designations for primary care, mental health, and dental care. And so these shortage designations, they allow us to utilize federal and state workforce programs to recruit and retain healthcare practitioners in those underserved areas. We also see workforce shortages in rural jurisdictions. So demographic trends in rural areas reflect an older and less diverse population, and particularly rural areas tend to experience higher workforce shortages and poorer health outcomes. So when we look at that, we see that also when we look at our shortages, we also see that these rural counties have the highest percentage of full county HPSAs compared to non-rural areas. So the workforce shortage is more acute in the rural settings. Some commission updates as well, and I'm skipping over most of these because Kim touched on these, but the work group on Black, Latino, Asian American, Pacific Islander, and other underrepresented behavioral health professionals had its initial meeting in November. Next meeting is scheduled for February, and those findings or recommendations are due on or before July 1st. And so we're on track for that. The Behavioral Health Workforce Investment Fund was established to provide reimbursement for costs associated with educating, training, certifying, recruiting, placing, and retaining behavioral health professionals and paraprofessionals. And the Maryland Healthcare Commission is coordinating that with other agencies to conduct this comprehensive workforce needs assessment by October. And I want to dive into the issue of this data, the data center clearinghouse, because I think it's actually really critical to be able to understand what our workforce challenges are and be able to set us up for the coming years and decades. And I'm glad that you mentioned that, Senator Vital, about the fact that this happened in Virginia about a decade ago. So what are our healthcare workforce data needs? This commission recognizes that healthcare workforce data limitations and gaps have recommended the need for formalized, robust, and real-time system of data collection and collation so that we can understand what the state and local level gaps are and use that to understand where the demand truly is. And so as part of that, going beyond simply there's a shortage of doctors or nurses or mental health professionals, but being able to understand within that, are there a shortage of particular specialists, medical specialists, dentists for children, dentists for adults, what types of behavioral health workers? So though healthcare workforce licensure data is collected and available by a wide variety of sources, there are limitations right now that we have in terms of availability, quantity, quality of the data we have across these disciplines. So when we look at the licensure data that comes from the occupational boards, they show individual active licenses, but we don't have aggregate information regarding other key elements that are going to really tell us where clinicians are serving. So what are the provider demographics? What are the actual hours worked per week? Percentage clinical services versus management supervisory research. Are they specialty? What practice sites do they have? Languages used? And so the current data just shows us kind of this large aggregate, but it doesn't allow us to dive in. So with that, what are our current workforce data activities? We completed our assessment. So this is the Preparing for Maryland Statewide Healthcare Workforce Data Clearinghouse, our landscape findings. And as Kim mentioned, Virginia really is the gold standard. They're really doing a great job. And so looking at that like, landscape analysis, we compared other states' infrastructure costs. What are the other organizations that are collecting that data? And then how can we use those to profile Maryland stakeholders? So our strategic planning activities for this data center are to bring together these essential stakeholders, to discuss support for this, gather their thoughts, and we have a wide range of participants who are part of this work, including members of the General Assembly and a variety of other professional associations as well, and state agencies, to be able to pull this together. And the goal is to discuss what are the workforce data points that are currently being collected? What are the current data collection methods that are being utilized? What are the necessary steps to improve sharing of that data? And that is a big issue that comes up. What's our capacity to collate, store, and then use this data? What are the resources we need? What are the additional data points we have, and also the additional commonalities we need to build into these different data collections? And then what are the longer term funding support and solutions? And so by doing that, we'll put ourselves in a position to be able to have more point in time picture with real time accessible data on the fluid workforce trends in Maryland. And it also will allow us to identify shortages beyond federal definitions and really get it to a more granular level at the state as to what we mean by that in terms of specialties, locations. So we've had a number of discussions with our partner agencies. Department of Labor, healthcare data sharing and coordination has been critical to the work that we're doing. We've had work group and council discussions regarding these data needs with the Commission to Study the Healthcare Workforce Crisis, with our MLARP, the Maryland Loan Assistance Repayment Program for physicians and nurses, with that advisory board, other agencies. And then we have a really important regional partnership that we're participating in with DC and Virginia, that is coordinated by George Washington University, which does a lot of workforce development and training work, and they're national leaders in this area. And so we're particularly excited to be able to engage with our Virginia colleagues on this, as I was just mentioning, and be able to pick their brain and see how we can adapt what they've done for our purposes. And so switching from the workforce data to what are some of the programs we have right now, we have a number of loan assistance programs. So the Maryland Loan Assistance Repayment Program for physicians, physician assistants, and newly added is for the nurses and nursing support staff. We also have DentCare Loan Assistant Repayment Program, and that is that newly increased the loan repayment to dentists to $50,000 per year for 3 years, and added dental hygienists for $10,000 per year for a 2-year commitment. But it doesn't carry any funds with it. One key part of this program is it does require those recipients for this DentCare program to treat a minimum of 30% of their patients who are Maryland Medical Assistance Program recipients. Another key program we have is the income tax credit for preceptors in areas with healthcare workforce shortages. So this is a program for medical student preceptors, nurse practitioner student preceptors, physician assistant student preceptors, and RN and LPN student preceptors. And the goal is to improve the number of graduating healthcare professionals and support the recruitment and retention of healthcare professional workforce in Maryland. This is through an annual application cycle, and the program authorizes a credit against the state income tax for individuals who serve as uncompensated preceptors in certain preceptorship programs in workforce shortage areas. So from 2016 until now, the program has grown from just medical students and nurse practitioners to the expansion of the groups that I just mentioned. And there is a report due in 2025 on this program. And the last program I want to highlight here is our Conrad 30, our J1 visa waiver program. And so this supports recruitment of needed primary care and specialty physicians into shortage areas, especially those federally designated HIPSA programs. Our Office of Population Health Improvement reviews these applications and makes recommendations to the U.S. Department of State for foreign-born physicians requesting waivers from the home residency requirement following completion of their medical residency in the United States. So it's a way to retain those foreign-born physicians in our state to work in underserved areas. And this waiver is granted in exchange for the physician's agreement to work in the underserved area for 3 years. In 2023, we recommended 28 successfully. So far in 2024, we've got 26 recommendations to date and continuing. Our Office of Oral Health has a HRSA grant to build a diverse and dynamic workforce. And this is really to address the shortage of dental professionals. And what's exciting about this is that it's really focused on building the dental workforce, and there are not a lot of efforts around that. So the Pathways to Bright Futures program connects youth in dental health professional shortages areas with dental professionals through various activities. And along that line of introducing younger folk to these professions early, it's looking to do this in Baltimore City, the Eastern Shore, and the Appalachian regions, which have a shortage of dentists. And so we're looking to understand the impact of this program. This is a new program, and we'll have more on that as that program unfolds. Maryland Area Health Education Centers are another key effort in our rural recruitment and retention efforts. We have AHAC centers in the western and eastern shore of Maryland. There's also a central region AHAC that's run through the University of Maryland. And these offer community education partnerships in underserved parts of the state to address recruitment and retention. And as I mentioned, particularly on rural recruitment and retention in the eastern and western portions of the state. And lastly, the MDH School Health Services Program, our workforce assessment is underway, and we will share those findings when we have them. And lastly, I want to highlight a couple of positions that I think are a really demonstration of our commitment to this work. One is our Public Health Workforce Director. This is a new position that we've added to public health to be able to identify how we develop and build the workforce, the public health workforce, not just at the Maryland Department of Health, but to improve those processes throughout the state. This is part of the federal government's efforts to fund development of public health and funding to us as a state. This is one part of that. The second is our Healthcare Workforce Director, and that's a position that's established within the Office of Population Health Improvement that will be overseeing all of the work that I was just mentioning. And so with that, I want to thank you for your time and happy to take any questions.
Thank you, Dr. K. Vice Chair?
Yeah, I just want to follow up with the Conrad 30.
Mm-hmm.
Is that's just for physicians, not nurses?
That is correct. That is a federal program that is just for physicians.
Okay, that's a federal program.
Correct.
Okay, but they can get their waivers, and as we just said, that kind of cuts a lot of the red tape.
So that program is for, so typically a foreign-born physician who does a residency here has to return to their home country.
Oh, they have to
That's the requirement of the visa under which they come. But the
Okay,
Conrad waiver allows them to stay in the United States and practice in an underserved area.
okay, but are there any nursing programs that mirror that?
At the federal level, not to my knowledge, but I can follow up on that to
Okay,
see if there's
yeah, I
anything.
mean, because it seems to me, nurses, you can't have a hospital without nurses, so
Mhm.
we're doctors. We're anybody else. We're housekeepers.
So if there are no other questions, I have a question for Dr. K. We talked about the educators, the preceptors. Do we know in Virginia if they've done something to expand the number of educators? Is that something they've done?
I don't know the answer to that, but I think it's a good question and we can follow up on that.
Because I hear we get 10 times as many applicants for medical school in Maryland than we have educators to
Mhm.
educate them. And so I think if we want to grow more doctors and nurses and medical professionals, we need to make sure we have the education opportunities for them.
Mhm.
So thank you for following up on that. Any other questions at all for Dr. Caliano-Rama? Oh, I'm sorry, I can't see your light. Why can't I see your light?
I didn't turn it on.
Oh, that's why. Thank you, Senator Warren.
Thank you, Madam Chair. Thank you for being here. I heard from the last presentation and this presentation, but I have not, we talk about workforce and workforce shortages, but we have, I think, about 16 workforce development boards, workforce service boards in the state. Have you guys collaborated with them or worked with those workforce boards throughout the state because they're connected with underemployed or unemployed individuals here in Maryland? I wonder if you guys have built a relationship with them so they can also help with the shortage.
So I know that's one of the items that the secretary is really keen on, is how we can consolidate those efforts, because there are so many different committees and workforces. But on that specific topic, we can pull some information on how we're working and how we're trying to pull that together.
Thank you. Just for the record, I work for one of them, one of those agencies. So I know for sure that it's not happening in the tune that it should.
Okay.
And I know that we should, as an agency, try to work with them so that we can bring more nurses or bring up these shortages that are happening around the state as well.
Okay.
Thank you.
If there are no other questions, this will end the briefing with Dr. Caliano-Rama. Thank you very much. Nice to see you again.
Thank you.
And next we have the Health Occupations Board's update, and Dr. Laura Herrera Scott. I think, is she here? Oh, there she is. Couldn't see. Is there anyone else you'd like to bring up with you?
Yes, Erin McMullen, Chief of Staff, and Rhonda Scott, the new Executive Director of the Board of Nursing.
Thank you.
Oh, and sorry.
And
And Sam Paul. Good afternoon, Chairwoman Vital, members of the committee. I'm going to give an overview of the health occupations boards and some
Dr.
observations.
Scott, will you pull the microphone a little
Sure.
closer to you, please? Thank you.
Is this better? Great. So I'm going to give an overview of the occupations board, although you heard a little bit from Kim Heiner as well as Dr. Caliano-Rama. So I will be quick, and then we'll move on to get an update on the Board of Social Work Examiners and an update on the Board of Nursing. If we can go to the next slide. So as was already mentioned, 20 Health Occupations Board license and regulate over 400,000 healthcare providers, with the largest board being the Board of Nursing, which, as you know, last year moved over to the Maryland Department of Health. So we'll be providing a detailed update on the work that we've been doing with the Board of Nursing specifically. And except for the Board of Nursing and the Board of Physicians, the Secretary of Health has no authority over the board staff or its board operations, including licensing, investigation, or disciplinary functions. And I call that out only because I get asked questions often about what my role is with the boards. The majority of the boards are special funded. 17 out of 20 set their own fees in regulation. Next slide. This is a list of all the boards. As you can imagine, they have varying degrees of staffing ratios and number of licenses that they manage. Most boards have some kind of online applications for initial and renewal applications. However, technology infrastructure varies. And as Kim Link shared earlier, about half do not accept online applications. So they're still paper-based. Data collected by the Health Occupations Board, as was already highlighted, is variable. So to all the questions that some of you have raised as far as where they work, other languages they might be speaking, cultural sensitivity, it's not captured in the database. And two very concrete examples, or maybe three, is if you look me up in the Board of Physicians, I'm a licensed, active, board certified physician, but I don't practice. So to count me in the denominator is not helpful to thinking about our workforce shortages in the state. The biggest thing really with the boards is the staffing, as I've mentioned, range and size, expertise of staff in the area of technology, human resources and procurement processes also varies. We also have high turnover rates that have been observed for certain positions, including the executive director positions. And so sometimes this contributes to the problem of timing of licensing. One of our smaller boards last year had half their staff turnover. Well, in a small board, having half your staff turnover is pretty significant. And so it really backed up some of the licensing that they were supposed to be doing. And we share all this because we wanted to share our approach to the sunset evaluation. Several boards are up for sunset extensions this legislative session. We're taking a uniform approach across all the sunsets. Specifically, we believe that a 3-year sunset extension allows ample time for MDH and the board to examine these functions and return to the General Assembly in 2026 with an update. Several states, as you already heard, do things differently than Maryland. And again, given some of the turnover issues and some of the delays in licensing, we are actively exploring some of those issues. And with that, I'm going to turn it over to Sam Paul, who's our Senior Health Policy Analyst at the department. He's been staffing the Board of Social Work Examiners, has been with the department for a year, comes to us by way of Oberlin and Boston College School of Law, and we're pretty excited to have him part of the team. So I'll turn it over to you, Sam.
Thank you, Madam Secretary. Good afternoon, Chair Bidle and members of the Finance Committee. Thank you for giving me the opportunity today to provide you with an update on the work group on social worker licensure requirements as established by SB 871. This work group convened for the first time on October 25th of the previous year. In that first meeting, it set up its meeting cadence. It began to meet on a semi-monthly basis on Tuesdays, and it agreed to hold a series of briefings on the state of social work licensure requirements in Maryland. So in our first meeting on November 14th, we discussed social work licensure requirements and the ASWB exam passage rates. They specifically looked at the licensure requirements in the state of Maryland and compared them to our surrounding states, and also took a look at the demographic disparities in passage rates for the ASWB exams. In the next briefing on December 5th, it discussed alternative pathways to social work licensure that have been developed in other jurisdictions, and the alternatives to examination for licensure that have been developed in other professions beyond social work. It discussed the methods by which jurisdictions have implemented transition processes to facilitate licensure requirement changes. Additionally, in that briefing, the work group reviewed the scope of the Board of Social Work Examiners' practice and responsibilities to give members an understanding of how any recommended changes they provide may impact the board's operations. In the December 19th briefing, the work group discussed the fees for the ASWB exams, as well as licensure application and renewal fees for social workers. These fees were also compared with the exam, licensure, and renewal fees for other health occupations, such as nursing, professional counselors, and psychologists. This was a particular area of interest for the work group members, as many had cited the high cost of exam and licensure fees as a great potential barrier to licensure. The work group also discussed the required supervised hours of social work experience that applicants must receive before becoming licensed, and the cost of obtaining those supervised hours. In our final briefing on January 9th this year, the work group heard a presentation from Dr. Judith Mounty, a practicing licensed clinical social worker and a member of the work group who is representing the Maryland Association of the Deaf. She gave the work group a presentation of the challenges faced by deaf and hard of hearing candidates for social work licensure, and provided the work group with several suggestions for how to increase equity in both testing and licensure for those social workers. In that same January 9th briefing, the work group discussed the assignment of subgroups to fulfill the reporting requirements as laid out by Senate Bill 871. And the work group is splitting into 4 bodies. The first will be a policy subgroup that will focus on recommendations such as supervision requirements and disability accommodations. The second will be a work group on the schools, programs, and universities of social work to discuss social work curriculums and continuing education requirements. The third subgroup will focus on barriers to testing for candidates, including exam fees, licensure fees, and the cost of preparation for the ASWB exam. And finally, there will be a group on that will be focused on making recommendations on testing and licensure for the use of the ASWB exam for both the master's and bachelor's level license, and as well for completing the licensure analysis of all levels of licensure as required by SB 871. These subgroups will meet on a monthly or semi-monthly basis, depending on the schedule of those work group members. And the main work group will shift its meeting cadence to the end of every month to give the subgroups time to meet and develop reports on the progress of their work. So this is the timeline that the work group is hoping to meet moving forward. The subgroups and general work group will convene this month and will continue to meet on the cadence of semi-monthly or monthly subgroup meetings and a monthly larger work group meeting at the end of the month, throughout the month, from now, January, through the month of June. By January 31st, we are planning to submit our preliminary report to the legislature. It will include much of the information that I have covered today and give a more detailed analysis of it. And by March 31st, we are planning on submitting the report detailing recommendations on the use of the ASWB exam for the master's and bachelor's level licenses. After those two reports are completed, we hope to continue on our schedule and complete our final report and submit it to the legislature by the due date of December 1st, 2024, as laid out in SB 871. Thank you.
Thank you for that presentation. We spent a lot of time last year in committee and in work groups trying to figure out what to do with the social work exam. So it looks like it's going to be another year before we have a final recommendation. But thank you for your work. Do I have any questions from any other senators? Thank you. Dr. Scott, I think it's back to you.
So now I'd like to turn it over to, let me first introduce, so as you know, the Board of Nursing came over to the Board of Physicians, the Maryland Department of Health in May, shortly after, or April 28th to be exact, after the bill was signed. We immediately got to work on understanding what some of the issues were with the board. Myself, Erin McMullen, and Kim Link did what I will refer to as kind of like a speed dating. We went into the agency and met with every single person in the agency, met with them for about 20 minutes just to get what was working, what was not working, really understand some of their pain points. So we had started making a list, and in parallel to that, we had an RFP that we had put out for the consultant to come in. So what you're going to hear is all the findings, not only the work that we did, which aligned with the consultants, but also the OPEGA analysis, and then the work that has been underway since those reports have become available. And after Rhonda Scott, who served as the deputy director for the Board of Nursing, she stepped in as the interim director and just did an incredible job helping move the agency forward, especially as it aligns with the recommendations. And so we formally named her into the role of the executive director in September of last year. So I'll turn it over to Rhonda Scott, the executive director of the Board of Nursing, and Erin McMullen, chief of staff, who's also a nurse by training and has been helping to lead much of the work that's also happening at the Board of Nursing.
All right. So Rhonda and I are going to hand it back and forth throughout the presentation. Truthfully, I feel like that alone is illustrative of how closely we've been working together to address some of the components of House Bill 611 from last year. But I would also be remiss if I didn't just thank the committee for their attention to this issue last year. I think it really forced the board and the department to work together in a way that's really collaborative, but at the end of the day, really just improves health and safety for Marylanders and the nursing community writ large. So as the secretary said, there was this bill last session. There's been 2 independent evaluations conducted since last year. One by a independent consultant that the department had to hire in accordance with the bill. The second by the team of analysts at DLS with OPEGA. And really those 2 reports, I would say, built common themes between the 2 of them. One was really internal, looking at internal board activities, and the work done by OPEGA really took into consideration comments, feedback, things that we were hearing from the nursing community writ large. The themes and findings for that are listed on this slide. You can see there were 5 different areas. So before the legislation even passed last year, we got to work on writing an RFP to get that independent evaluator on board as required by the bill. So we did a competitive emergency procurement. We received one bid. Ernst & Young was awarded a contract. We worked with them over the summer to do a evaluation of the board on a variety of areas, several of which were identified in the legislation that you passed. That report was provided to all of you back in September. And then the OPEGA evaluation was sent to you earlier this month. December. It was sent to you in December. But it really highlights a number of different areas. As we walk through the slides, we've tried to crosswalk them. And we won't be speaking to each individual finding, but hoping to tell you at a high level what we've been up to the past 8 months since this bill was signed. So with that, I'm going to hand it over to Rhonda.
Thank you, Erin. Good afternoon, Madam Chair, members of the committee. Thank you for this opportunity. So in partnering with the department and the support that we have gotten from the department, it's enabled us to drastically decrease our the number of constituent inquiry cases that we've gotten from customer service standpoint. We have been able to close out the year with 0 outstanding cases, and we've kept that up over the last couple weeks into the new year. Thank you. And additionally, we have been working with the MDH Communications Department to assist with responding to inquiries and just to address immediate communication concerns and things like that. So it's really helped us with improving customer service and reaching out and being able to answer the inquiries that we receive from our constituents.
So you've heard a little bit about the technology issues that are facing the boards writ large. I'm not going to spend a ton of time talking about this, but I do just want to share that over the past 8 months, we've really worked closely with a shared vision between the board and the department to really modernize the Board of Nursing. Foundational to this was really getting the board reconnected. So some of you probably remember in December of 2021, there was a cybersecurity incident at the department. The board was not reconnected to the department's network until this past June. Once the bill had been signed, we started working really closely with the board to make sure that that was top of mind. Really nothing we could be done to address some of their other technology issues until we did that. I really want to underscore that that just wasn't important from a cybersecurity standpoint, but just from an efficiency standpoint. Rhonda can speak to this more, but I think it really hindered the ability of the board to just do their work every day without really being reconnected. I think most of us would agree if we lose access to our internet, we really can't do a lot of our work. So that was really fundamental. And through further partnership with the MDH Office of Enterprise Technology, we've been able to do a few other things. Reconnection has allowed us to migrate the board's licensure system over to our secure network. It's also been able to facilitate us moving the board's website to the department's network, which is underway now. And as it relates to constituent services, that'll allow us to help work with the board to really make sure that the website and the face they're putting forward to the public and nurses is really, frankly, easy to understand and access. So another area that's been identified by the independent evaluators and also in the presentations you heard earlier really does have to do with that licensure system. I won't spend a ton of time on this slide, but just to say the board has a front end and a back end system. They have 2 separate systems that staff have to work through every single day. There's one that's public facing for nurses where you go and enter your licensee information. Staff then has to manually move that to a back end system where the licensing actually occurs. So not only is that inefficient, it creates opportunities for error. Anytime you're picking up that data, moving somewhere else, it really can create additional problems for nurses and certificate holders that are seeking licensure. So right now we've extended those current software applications to get us to a bridge to hopefully what is going to be a new place. So we also have a major IT development project or MITDP to implement a new licensure system for the board. As mentioned previously, the board they license the vast majority of healthcare professionals in our state. And really, it's a key goal of this administration is to modernize this platform. And our hope really is twofold for that system. So first, it'll be that end-to-end licensure system for nurses and certificate holders. So that would eliminate the need for us to have these two separate systems. But we're also hoping that it can provide the back-end data necessary to address all the things that you heard from the earlier panels. So it would give us data around demographic information, where nurses are working, and really feed into the broader workforce conversations and needs that we have at the department. I also just want to say that it's really our hope, the secretary mentioned earlier, these other boards are not under we don't have any ability to weigh in on their licensure and oversight activities, but it is our hope that this system that's built for the Board of Nursing can really serve as a vehicle for the other boards to address some of the workforce issues that have been highlighted today. And although that MITDP was funded in prior fiscal years, House Bill 611 was really the reason that the department has been able to proactively work with the board to start talking about business requirements. Our CIO is heavily involved with the board on working on those now, and that proactive engagement wasn't really occurring prior to the bill signing. I'm not going to go through the recommendations listed here on technology or the next slide, but you can see that many of them will not be addressed until we truly do get that new licensure system, and we're working on building those into business requirements. So with that, I'll turn it back to Rhonda.
Thank you, Erin. Just briefly, so both evaluations did identify funding gaps in the board and our fee structure is one of the things. So what we're doing is we're conducting a national landscape and looking at licensing fees to determine where our fee structure needs to be. And what we are planning is that by the summer of this year, we should have a fee structure published to move forward with that. And then I'll move on to the complaint response and investigation piece. So one of the things that our collaboration with the department has enabled us to do is to bring on additional, per the recommendation of the evaluators, is to bring on more staff, particularly in the area of investigators. So we've got 10 additional non-nurse investigator positions. We've already made offers to 7, so that is pending. But what we have already established is a plan to address the backlog of complaints that we currently have. And once these folks are onboarded, we will be able to implement that plan.
And then I'm just going to close this out with a few more comments regarding staffing. So, making a leadership change at the board and Rhonda's appointment as executive director was really a big step forward after HB 611 was signed. But there's other recommendations that were made by both OPEGA, but also in the independent evaluation that are going to require more partnership between the board, the health department, and then the Department of Budget and Management. There's recommendations that are on the next slide as well that speak to that. But ultimately, MDH does agree that we really do need to look at employee retention at the board, and we're going to do that within the context of our broader internal look at how we're staffing at the department and also the boards and commissions. And then finally, just a few more things to highlight. Nearly all of the volunteer boards, so the folks that are appointed by the governor, there's 14 of them. Nearly the entire board's turned over. 10 out of 14 of the volunteer board members have been appointed. There's recruitment underway for the remaining 4. We've also, made a number of changes at the department on how we approach employee engagement. The secretary holds regular town hall meetings that are both in the department, but also with available to those staff that are at our boards and commissions. As the secretary alluded to earlier, we've spent some time out at the board to meet with staff. Rhonda meets with the team regularly, and we're in, frankly, constant communication on addressing a number of the issues here. So Madam Chair, with that, that concludes our formal presentation. We're happy to take any questions that you have.
I think that was like speed dating, Erin. Okay, I have some questions. Senator Guile.
Thank you, Madam Chair. And thank you, everyone, for your presentation. Very much appreciate all the work that you are doing. I can't help but bring up the Washington Post articles. I know that those were all very distressing for all of us to read, and I'm sure that those were very distressing for you all. And I appreciate all the work that you're doing, in particular to address the backlog of investigations or open cases. From your perspective, are some of these improvements that you're doing, do you think that those will address some of those issues that were raised in the Washington Post articles? And I'm sorry to ask you two questions too, but I figure it may be help and more efficient to do so. On page 16 of the of the PowerPoint that you have here, where it lists the total number of open cases, I know that there was a sort of priority that was given to some of the cases. Does this include all of them, or is there some sort of differentiation between that?
So I'll take the first question first, if
Sure,
that's okay.
please, thank you.
Absolutely, is
Yeah.
the short answer to your question. You know, we have all read the Washington Post article, and certainly as we think about changes in the board, want to make sure we capture things like that moving forward for sure. So absolutely on the first part. On the second part, the table that we have here is related to the constituent services. And I think you're talking about the
open
complaints and
cases,
more,
yeah.
more formal investigations.
Mhm.
And that there is a backlog. But that was why we brought on or approved 10 new positions for non-nurse investigators to
Mhm.
triage those cases, and the lower acuity cases going to the non-nurse investigators, while the more egregious cases going to the nurse investigators. So far, 7 of those 10 positions have been filled or made offers on. There's 3 more that need to be filled, but we've added significant number of staff to address the backlog. So the table here only addresses the complaints that come in through constituent services, not the actual investigations in the backlog that's there.
Okay, and just quickly, the 10 new investigators, that's 10 new since which date,
Since when?
if you know?
It's like the past
Maybe
couple
in the
months.
past couple
Yeah.
of months.
In the
Yeah,
past couple months?
yes.
Okay.
But
All
only 7 are filled, 7 right now.
Only
There's
7
still
offers.
3 that they're working on.
And they've been.
So there's 10 new open positions, 7 of which are filled, 3 that you still need to fill.
Correct.
Is that correct? And those are all full-time positions?
Yes.
Correct. Okay. All right. Thank you. Thank you, Madam Chair.
Senator Howell, thank you for your questions. And I was going to the same place, but I want to go a little further. From the Washington Post article, I read that the one midwife that we're very concerned about had 2 felonies in Virginia, and the board knew about that, and they still licensed her in Maryland. Is that correct?
Well, I can't really speak specifically to the case, but I know that the individual was licensed. Now, as far as what they were aware of, I can't really speak to, but I know that the individual was licensed.
So when we had our conversation, I was told that you do a criminal background check
Yes,
on everyone.
yes,
So she had 2 felonies that would have come up in a criminal background check.
yes.
So I just want some assurances that we're not going to license professionals in Maryland that come from another state with a felony. So if I could get that assurance from you in writing, I'd appreciate that. It was just of great deal of concern to me. Senator Lamb?
Yeah, thank you, Madam Chair. Good to see everyone again this afternoon. I wanted to kind of follow up on Senator Giles' question there, particularly about the Board of Nursing. You know, so I chair the Joint Audits Committee. OPEGA falls within the purview of joint audits, and in their report, they recorded a backlog of over 2,800 board complaints. And I think even at the rate of that we're going through to address those complaints, if we were to have no new complaints, it would still take us like 5 years to get through all the backlog of complaints. Some of these complaints obviously may be unfounded and whatnot, but there's no way to know whether that's the case, nor to know if we're allowing unsafe providers to be able to continue to practice pending those complaints. So what is the plan to address this, you know, potential 5-year backlog of complaints?
So what we've already done is the board staff plan to present to the board at its meeting this month on the request to delegate them authority to triage cases, because previously our cases were triaged by volunteer board members, and they aren't able to, of course, meet as often to review the cases. So board staff will be able to review the cases as they come in, triage them in accordance with the appropriate priority level. so that that can be an ongoing process that's done more frequently than in the past. And then as far as the additional staff that we're going to get, that's going to be a big part of being able to conduct investigations for these cases.
Do you have an estimate of when you think the backlog will be completed?
I can't really estimate now, but it will depend on once we get everybody onboarded and trained and you know, rolling with the actual ability to conduct investigation and review the cases.
When do you think you can get an estimate of when we may be able to get a deadline on clearing the backlog?
I can follow up with you maybe in the, I don't know, we'll follow up. I can't really give an exact date, but we can certainly look into, you know, what will be the plan that we have implemented, the time it will take to review each case, and then we can provide you with the an exact estimate of clearing the backlog.
So if you can get back to us on a date when you may be able to give us a date, that would be great. As a starting point. I guess maybe this question is for the secretary. Is there a date in mind that you would prefer to have this done by? You know, I guess
As soon as possible.
Okay.
No, so I know that we'll get you a hard
Okay.
date. The 7 people are just coming on. They need staffing and training. So, and it also goes to the triaging of the cases. So I would say in the way it was done previously, the weight of each case was almost equal to, so everything was going to a nurse. And so that just slowed the process down. But you know, there are lower acuity cases that you can not dismiss, but file away, document, because of, you know, I don't know, they were rude to me, you know, could be a complaint as an example, versus something egregious like wrong medication or assault or something like that. So I think by triaging the cases, we'll have a better sense based on the nurse investigators that we have, and then this new non-clinical investigators that we have, how we'll be able to move through the cases, with the lower acuity cases clearly taking much shorter periods of time and the longer. But I don't even know at this point of those 2,800 cases, what the breakdown is across the acuities. And that's the piece we need to get to. And then we can tell you about how long it will take.
Okay.
So I will, how about commit, certainly in the next month, would that work? Especially since she's meeting with her board to go over the process.
Okay. Yeah, I mean, the triaging I think is important because, you know, each individual complaint could be very different,
Mhm.
right? And to the point of there being felonies and past records, it really also depends on what type of felonies, right? That doesn't necessarily disqualify a nurse. We have a nursing shortage, as was heard already. Doesn't necessarily disqualify, depends on what actually occurred with that individual and what that felony is related to, as to whether that individual could be licensed or not. So obviously all of that is contributing to kind of that workload that the board has to go through to review these individual complaints.
And I just also want to back to the IT. The system is as clunky as it looks in the slide. So even pulling information out to do the investigations is clunky. So that also slows the team down, but we'll get you an estimate with an ETA of when the backlog will be reduced at least by half, if not completely resolved. And we'll know more once we know how many of each of the different acute cases, you know, of the acuity of the cases there are. If the majority of them are lower acuity, it'll go faster. The majority of them are higher acuity, it'll go longer, but we'll get back to you.
So a follow-up question, this one pertains to the Board of Social Work then. We're also hearing a rising number of complaints about the Board of Social Work. And, you know, I think all of us want to avoid having the Board of Social Work kind of continue along this path that could end up in a very similar situation to the Board of Nursing. And so what specifically are we doing about the Board of Social Work in order to head off of this path so that we don't end up in the same place?
So I will tell you, part of the problem with the Board of Social Work has been the turnover of the executive director. I think they've turned over a couple times, and for a variety of reasons. And so with Kim Link, who presented earlier, we're certainly working to try and stabilize that board. So I don't have a specific answer for you on longer term, how we stabilize them overall, but it's hard to do it without an executive director that stays in the role. So we're trying to understand what about the role of the board that people are leaving in the position as quickly as they're turning over.
Okay. This also pertains to the Board of Social Work. I think it was mentioned during the presentation that the report with the recommendations on what to do about some of the disparity with the social work exam is going to be sent sometime around January 31st.
No,
And
March 31st
March
Sorry,
31st.
March 31st,
Okay,
yes.
March 31st.
of this year.
So I guess my concern is this committee's obviously been very familiar with this issue, and the report was actually due in September. And so it's been pushed back quite a few months. And the intention of the September due date was that we would be able to introduce legislation for this session to be able to address some of these issues that are still ongoing. The bill draft deadline obviously is tomorrow. And so we're going to get this report well past any ability of this legislature to be able to address this in the 2024 session. Do we have any assurance that these reports will be coming forward in a timely manner?
So yes, part of the delays in the report was we were waiting for the appointments for the actual the people that would be on this particular commission. So it took a little bit longer than expected, but as soon as they were all named, we quickly assembled them and got to work, as you can see laid out in the calendar that Sam shared with you. So yes, our expectation is to have the March 31st report due to you on March 31st, if not before,
Okay, with the understanding that we won't be able to implement anything at that point.
with the understanding.
Yeah. A broader question about some of the other boards that aren't represented on this panel. We've been hearing that there may be a potential to merge some of these smaller boards. And so can you share the department's view on where you think this may be going with whether it's a good idea to merge all of these smaller boards or not?
So I will just share that some of the smaller boards are small. And when you have turnover in the boards, it impacts their ability to process this license timely. Again, we don't have oversight of the other boards, but by virtue of their size, it sometimes makes them inefficient. And we're also have infrastructure across the 20 boards that we have that maybe could be streamlined.
Okay, so I guess more to come on that.
Yes.
Okay. Last question then, because I know we, to address these sunset reviews that come before us, and there's a request, I guess, to reset all these sunsets at 3 years. That's going to increase the number of sunset bills that we see in the subsequent years and have to deal with. Do you feel like that you actually need the 3 years in order to do your assessment of this? Or, because you could always bring forward a bill at any point in time with new findings or directions that you want to go with. Do we have to go with a 3-year kind of wait as part of these sunsets?
Well, the boards are all requesting different time periods. And so we think 3 years based on the work we've been doing with the Board of Nursing, based on when I was here as deputy secretary years ago, working with the Board of Physicians, it takes a year plus just to do the evaluation and to get things moving, whether that's related to enterprise technology, whether it's related to licensing software, especially given our procurement lengths of time to get a procurement done, and even just evaluating the work and the volume of the work and what's the best way to do that work. And so the idea of standardizing the 3-year, are there lessons learned that we can replicate across the boards? For instance, as Erin already said, certainly the software or the business requirements that we're currently collecting for a new Board of Nursing software, our hope is it is a software platform that's applicable to any board. So change out nurse and put in whatever the clinician is. So on the front end, the user experience to not only enroll for the first time for their license or renew their license is simplified, and you can track where your license is in the licensing process. But on the back end, then we learn more than we've ever learned about our workforce. Are they coming from out of state from schools? Are they coming to Maryland to go to school and then stay? Where are they working? Other languages, cultural competency, et cetera. So that's certainly our hope. And so we think in that 3 years, even if we don't have a fully functional new licensing on board at the Board of Nursing, we will at least have had a vendor selected. And that's just one example that would allow us then to see where there are opportunities to align the boards.
Okay. All right. Thank you, Madam Chair.
Thank you, Senator. Senator Kramer, you've waited patiently.
And thank you for that, Madam Chair. Madam Secretary, after the questioning you just had, I don't want to give the appearance that we're piling on. But this is an opportunity to have a question with you. So I appreciate that you're here. And I'm going to preface my question first by saying, there was a report from the U.S. Department of Health and Human Services Office of Inspector General this past year, and it does deal with the issue of backlogs. In this case, Maryland and Kentucky are tied as the two largest backlogs in the nation of nursing home inspections. Having set that background, Montgomery County, for I believe a decade, had an MOU with the state to do the inspections of nursing homes in Montgomery County on behalf of the state. That MOU expired, from what I understand, nearly 2 years ago. The county has been trying desperately to get the MOU renewed. And in fact, the deal is spectacular for the state because the county has been splitting the cost of doing this state responsibility on behalf of the state, but the county's absorbed half the cost of doing so. My understanding is they have been trying to get that MOU renewed, that they haven't been able to, and that there is a tremendous backlog of nursing home inspections statewide, but I'm talking specific to Montgomery County at the moment. And the county is saying, we can start doing this. We understand the state has its issues. We're willing to step up and do this for the state. The state is not giving us the green light to get back to doing it. So my question of you, Madam Secretary, what is it going to take to get this MOU renewed? And is there any reason the state can't do that tomorrow and let Montgomery County get back to inspecting these nursing homes? Because quite frankly, this is a terrible look for the state of Maryland to have the most vulnerable population in our state in these nursing homes tied with Kentucky as the two worst states in the country on the issue. So can we get this MOU resolved tomorrow?
So the short answer is no. Let me just say, I'm with you on being tied for last on the number of outstanding complaints. I just want to tell you what we've been doing in the meantime, trying to triage, same thing, the number of complaints we have. Some of them are very, very minor complaints, such as the floor was dirty, or like I said, in the Board of Nursing, the person was rude, but some of them are more egregious complaints. And so we're triaging the complaints. We've also looked at the number of complaints by facilities, so we can prioritize the facilities that have the most complaints. And in some cases, it's a significant number. So we are actively working on that. The other thing is, in the budget, we did ask for additional FTE so we could address the backlog. And so we did get resources in the 2025 budget to start addressing the backlog. So I just want to, you are right. We have a terrible backlog, but we are actively working it. And now with the additional resources, we'll be working diligently to resolve the backlog. As for Montgomery County, I am aware of the MOU. I'm trying to work with the team to understand why the MOU lapsed and why we couldn't renew it. So I don't have an answer, but even if I got an answer today to get a new MOU and get the lawyers to sign off on it, it would not be done in a day. So I will take that back and I will work with Dr. Kalyana Raman, who oversees the Office of Healthcare Quality, and work with the Office of Healthcare Quality to at least get back to this committee on what's needed to move forward with an MOU. And if we can't move forward, why? So we're clear on what's going on, but I don't have an answer for you right now, but I will work to get you one.
And I appreciate it can't be done tomorrow, but the county has been trying since October of 2021 to renew this MOU. So basically, it's well over 2 years. And I understand this predates your being in the position you're in. But quite frankly, now we have the new administration that has been in place for a year. And and the county is very frustrated that they're willing to take on this responsibility and the state just is not responding to them. And we have an answer to your backlog. Let the county do the inspections. So I would appreciate if you and I could maybe follow up on this I mean, how long do you think it's going to take after more than 2 years for the attorneys in your agency to figure out why this 10-year MOU, that it was a finite date is my understanding, so that it terminated and it just needed to be renewed? How do we get there without, because I feel the same frustration my county government does when we can't get a bureaucracy to come to the table and say, done. And quite frankly, ma'am, the buck ends with you at the top. So can you and I come to an agreement as to when we will have a definitive answer as to why or why not we're getting this renewed? And at least, and I'm sure my colleagues have an identical sentiment, but at least in Montgomery County, our county is willing to say, we'll step up to the plate to start getting in there and make sure these most vulnerable residents of the state are protected. So can you and I come to an agreement that this time next week, we'll have an answer after well over 2 years? Can we get there?
I will get you an answer no later than next Friday.
Thank you. And beyond just the answer, assuming there is no significant rationale for not renewing it, does that mean we'll also be able to get it renewed next Friday?
I cannot commit to that. So without knowing the details of why the MOU was not renewed, I don't have that details. I don't know the rules from CMS that allows us to delegate that responsibility, since the responsibility from CMS is delegated to the department. And again, I don't know the resources that are needed in Montgomery County off the top of my head. I don't know how many nursing homes you have that need inspections. So I cannot give you that level of detail. I can commit to getting you an answer by next week.
Thank you, Madam Secretary. I appreciate that. Thank you, Madam Chair.
Thank you. Dr. Herrera Scott, I know from conversations you and I have had on a number of issues that you really have inherited a lot of work that needs to be done. And I truly appreciate, and I know this committee appreciates the work that you're doing to clean up the backlog and create new programs going forward. And your entire staff has been really wonderful to work with. So Aaron and I have been worked on a number of issues together, and you have a great chief of staff. So I look forward to you continuing your work, and thank you for the work you've done so far. I think Maryland is very fortunate to have you as our Secretary of Health. My greatest concern is that you get exhausted and you leave us. So please don't let that happen.
Thank you, Chair.
Senator Washington, you have another question?
Yes, just really quick, Madam Chair. Thank you. Senator Lamb brought up a really good point that we have until tomorrow to request legislation. And I know one of the biggest things about the deficit in our workforce was the State Healthcare Workforce Data Center. And I wonder if there's legislation for that. Do you need legislation for that? Or is that already something that you're working on to develop?
For which?
Maybe it's for the previous, I think it's for the previous speaker.
For the data
center.
I think it's being incorporated into the licensing, if I understood that correctly. So you don't need legislation, you just need to create the programs to collect the data.
And right, and the ability to pull the data out of the systems that we have today. So we don't need legislation for that.
Got it. That's all I need to know. Thank you.
Okay, I think that's the end of this briefing, and thank you very much, and we'll look forward to continuing to work together. Thank you. We're gonna have a little 5-minute break while Tammy sets up the system for our bill hearing. So if you need to get up, get something to drink, come back in just 5 minutes. Thank you.